Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fowden, I'm the chair and organizer of Grand Rounds, and welcome back after a week off last week. And the sun has come out, so it must be summer. And we're reaching the conclusion of our Grand Round program. There's only a couple more weeks left before we take a break for the summer holidays. This week, I'm delighted to welcome Dr. Sarah Burgess-Castella, who contacted me a few months ago to ask if he could have a slot at Grand Rounds to talk about the important topic of equality, diversity and inclusion. He's a GP locally who works in the university. He'll tell you more about himself, but he's been working to try to improve EDI teaching and understanding in medical education within our undergraduate program, but everything here I think is going to be relevant to all of our practice, no matter what we do and whatever role we have. So without further ado, I'll hand over to Sarah for the rest of the presentation. If you could keep your microphones muted during the presentation. If you have a question, please put it in the chat. There'll be time at the end for turning a camera on and asking questions. And if you have a burning desire to give a talk at Grand Rounds, looking around the names here, there's some eminent people who I think could probably have a talk in their back pocket. Please do get in touch, because we have an empty slot next week. There's a couple of weeks, then we have some empty slots at the end of June, which I'd love to fill with something interesting, and anything that you have on offer, I'm sure would be interesting to this audience. And without further ado, I'll hand over to Sarah. Thank you very much indeed.
Hi, welcome everyone. I'm Sarah. I'm just going to give a couple of, spend a minute into myself, saying that I'm a GP clinically. I work with people experiencing homelessness in Edinburgh as my clinical job, but most of my work nowadays is academic, and I'm Deputy Programme Director and Year 3-4 lead for ScotGEM, which is a graduate entry medical programme, which is jointly run by St Andrews and Dundee in Scotland. I also work as a staff development tutor in equality, diversity and inclusion for the University of Dundee, and it's really with regards to that role that I'm here giving this talk. And today I'm going to discuss how we can support and discuss issues of equality, diversity and inclusion within medical education. I think it's increasingly recognised as being incredibly important, but perhaps often not as urgent as the constant fires we're trying to put out in our clinical or academic practice. And I'm very aware that it's exam season right now, so thank you for all attending today. Increasingly, however, I think we worry that EDI issues will be the fire. While there's increased recognition of importance, I think there's also a sense of vulnerability for both students and staff in understanding how we broach safely and manage the discussions which ensue. And I think some of the language that surrounds EDI makes it feel like a bit of a minefield, weaponized by terms like structural violence and microaggressions. The language is dynamic and it's changing. It should be. I think the field can be polarizing, and not knowing the right terminology can result in reactions creating defensiveness. And I think we need to try and make the discussions we have around EDI as safe a space as possible, as when we feel vulnerable, when we feel defensive, we're much more likely to say the wrong thing accidentally. As I'll discuss, I believe there's a big difference between intentional and non-intentional harm. We need to respect both intentions and the harm that may advertently or inadvertently arise, but separate those out. And doing that requires a degree of humility. And that's a word I'm going to come back to. And to respect that we can all say the right and wrong thing, but we're more likely to accidentally say the wrong thing when we feel defensive. In this talk, I'm going to cover a little bit about why I think about EDI now. I'm going to specifically signpost you to the Medical Schools Alliance Active Inclusion document, which many of you will be very familiar with. Then I'm going to talk a little bit about how we put the theory into practice. And finally, I'm going to introduce a staff workshop we've developed on equality, diversity and inclusion, which we're rolling out, and would love to see as many of you there as possible. So without further ado, why now? And I think the why now is because of a series of movements and an emerging evidence base, which have kind of come together. We're aware of social movements such as Me Too and such as Black Lives Matter, which have increased awareness of issues of discrimination and exclusion within society, and that includes within health and medicine. We're ever more aware of the inequalities and evidence-based demonstrating those within health, medicine and medical education. And there's acknowledgement that these are structural. That means that they're related to underlying political, social and economic structures that govern our lives in many ways. And 3 years plus now of COVID, I think, and the evidence base looking at COVID risk and how that is related to certain population groups, again, I think has demonstrated that structural racism and discrimination can increase our exposure to risk and our vulnerability to severe disease. As well as in medicine, there's a parallel movement across higher education to decolonize and diversify, sorry, this is high typo there, curricula. What does that mean? Well, decolonize, firstly, it starts with recognizing that much of the teaching and educational content with the curriculum, not just in medicine and across higher education, is framed by our colonial experiences in the past. And that might extend to how we view the roles of different population groups within society, and that these stereotypes might prejudice or advantage some groups. And that's a first step to us having an active process to evaluate and address that. And that includes by diversifying the population groups we represent in our teaching, and also how we represent them in our teaching, so we don't just reinforce and reiterate stereotypes. Specific to medicine, I'm going to signpost 2 documents. The first is the Race Charter by the BMA. And that had 4 main areas to focus on. That was supporting individuals to speak out, ensuring there were robust processes for reporting and handling complaints, mainstreaming equality, diversity and inclusion across the learning environment, and addressing racial harassment on work placements. And that's certainly been the precursor and driven a significant amount of EDI work within medical education, and is now perhaps been superseded to some degree by a document that was published less than 2 years ago, 1.5 years ago, and that was a document by the Medical Schools Council called Active Inclusion, Challenging Exclusions in Medical Education. And this is a really, really nice document. It's quite short, it's only 20-something pages, and it details different ways we can look at increasing inclusivity within medical education. And I'm going to focus on that just for a few minutes. So active inclusion, as I said, is the name of the document, and it's published by Medical Schools Council, and has some key principles which kind of pervade the document. Firstly, it draws attention to inequalities being more than just legal protected characteristics, and we're probably all aware that there are a set of legal protected characteristics, and they are age, disability, gender reassignment, marriage and civil partnership, pregnancy and maternity, race, religion or belief, sex and sexual orientation. But what active inclusion highlights is that whilst not a protected characteristic, the socioeconomic background of students are a key determinant of inclusion and exclusion. And in fact, the least represented population group within our medical student body in general are those from low socioeconomic groups. It draws attention to a sociological concept called intersectionality, and that describes how different social entities, different characteristics like protected characteristics or socioeconomic groups interact, and they can create different experiences of discrimination and privilege. And it's most commonly described in relation to the experiences of Black women whose experiences and level of prejudice and discrimination and disadvantage is greater than being Black alone or being a woman alone. It also draws attention to there being differentials between different groups of students, and that whilst differential obtained by different groups of students exists, there's increasing evidence that might be due to underlying curricular structures as opposed to differences between the individuals in those groups specifically. And the other side of the coin, there's evidence that by developing inclusive curriculum, this is evidence generally stems from the US, that we can create better doctors who perform better, but also doctors who wish to address health inequities within our patient groups. So it creates a doctor with a slightly different focus potentially. Within all of this, and perhaps a wee bit of a contrast to other aspects of medical education, students may be better informed and may be as invested as us as educators. And there's a real scope here for staff-student co-creation in terms of how we develop the curricula. And I think there's a fantastic opportunity to involve students and engage students and utilize this, but we have to be aware of something that's kind of called the minority tax, that students might feel obliged, or there might be an expectation that students from underrepresented groups should or may want to be involved without any expectation or reward. So really, really useful to engage our students and our student body, but we have to make sure that there's no sense of obligation that could actually make that sense of disadvantage worse.
Sarah, I'm sorry to interrupt you mid-flow, but we seem to be stuck on a slide. Have you been moving the slides on, or are you still on active principles?
I've been moving slides on. I'm on slide 10 on my screen, but obviously you're not.
We're not. Perhaps you could unshare and then reshare, and then we could get the benefit of seeing. Oh, there you go. Suddenly we're onto the slides have moved.
Oh, that's very interesting.
Okay,
okay, is that moving?
Tell me which slide I'm meant to be seeing, and I'll tell you if I can see it.
You're meant to be seeing slide 10, which says active inclusion key principles.
That one is the one we can see, so perhaps we were at cross purposes. But keep going. We think we're on the right page. Well, I'm sorry to interrupt.
On the right page now.
I'm just mentioning in the chat.
Great. So active inclusion encompasses all parts of the curriculum, and I'm not going to go through all the recommendations or all the examples it gives, but I thought I'd give us a set, one in different areas, to make it a little bit more tangible. And for example, within admissions, I think it's worth us thinking about the interview questions we use, how these might stereotype certain population groups, if they make reference to certain population groups, and how they may advantage or disadvantage students from certain backgrounds with assumed knowledge. Within the medical school, we need to make sure our induction and welcoming events are as inclusive and inviting as possible, and that they, for example, don't exclude students with certain types of disability, and that there are events that cater for those students that may have dietary requirements or don't drink alcohol. In particular, in terms of student co-created activities, this might be a really nice starting point in which to engage your student body, or our student body to get as involved as possible. With regards to student support, again, there are lots and lots of issues and lots of ways we can help students better in terms of EDI. But we need to think about proactive approaches for helping students and supporting students from non-traditional backgrounds. And I've just referenced a paper that's about 6 years old, which looked at students from widening access backgrounds and how those students often had different types of social network and social connection on entering medical school, but also as they went through medical school. And that limited some of the resources that they were able to have, and limited the kind of gains they could make. We needed to in terms of curriculum development, we can diversify our content. Many of us will be aware of Mind the Gap, which was the handbook, I think, developed by a medical student in London, George's, I think, which had clinical signs on patients with non-white skin. And I think, again, developments such as these can really help drive student learning, and again can involve students with the kind of co-creation process. And finally, an assessment. As an example, we need to make sure we can collect data on our students, our patients, and our examiners to understand firstly our baseline. What's the baseline in terms of diversity, and also to monitor improvements. We need to do so in a way that tries to account for intersectionality. And we need to try and do so in a way that can try and maintain some degree of confidentiality, or at least balance that. So from the theory to the practice, and what I want you to think about, perhaps after this talk, is who are you, and what the various aspects to your identity are. And what I mean by that is the way we see ourselves is partly also framed by how other people see us, and it tends to encompass our experiences and how we have reflected upon those, how those are related to the opportunities and challenges we've had, and how that defines the way we think, we act, and we react, and how we react to people who may be similar to ourselves or different from ourselves. And I think it's really interesting and useful to do that. You can spend a few minutes doing that, and certainly in our workshop, we ask the participants to do that, because it can change your notion of not only how you see yourself, but how you then can see other people. And I think one of the commonest statements I've had is that the sense that culture only applies to those from underrepresented backgrounds, and actually culture applies to everyone. And by thinking a little bit about our identity, we start to kind of unpick a little bit about what our culture is, what our unique culture is, and where that comes from, and what that means. And as we move from that kind of theory to the practice, I think we need to think about what are the principles of teaching or discussing issues of equality and diversity and inclusion in medical education. And I think there are broad principles which are incredibly important. We need to make sure it's relevant. We need to make sure it's connected. And I think 5, certainly 10 years ago, I think many staff and students might not have seen this as being especially relevant. I think this is absolutely less the case now. And I think there's a real clamour from a number of tutors and clinical educators asking for training that's nuanced, training that's relevant to medical education, training that's relevant to the cases and the patients that they see and the students and the difficulty those students have. And within that, as I said at the beginning, I think the biggest issue is often the safe space. The debate can be really polarised with changing language, and it's incredibly important to have a safe space and inclusive environment so people can ask naive questions without feeling that they're going to be shot down. I think there are certain models we can use to help that. And I think it's really important in any teaching that we do that we're not reifying certain population groups or chastising any population groups or groups of people for who they are. As the MSc Active Inclusion has really drawn attention to, whilst protected characteristics are critical, we need to consider aspects of diversity that are broader than that. We need to think about poverty, social capital, people's knowledge of language. I work at ScotGem, and we have a rural theme or kind of ethos, and the rural sense of being an insider outsider is also incredibly important. And whilst the underlying theory is important, much of it's derived from sociology. The language can be really off-putting, can be quite jargony. So I think it's important that we use cases to bring that theory to life and to make it real to educators and to students. So what I've been working on is a staff workshop for equality, diversity, and inclusion. And what we're trying to do is have something which provides a little bit of nuance that maybe addresses those areas which are a wee bit grayer than some of the black and white issues or scenarios that I've generally seen in my previous equality, diversity, inclusion training, because I think it's often those grey cases that are most difficult to deal with, and where we have to balance different agendas and priorities. And the key framework, or the key, I guess, take home probably from the workshop, is an idea which is called cultural humility. And it's a way, in essence, of facilitating a safe space. It's a way of considering broader characteristics and a way of considering intersectionality. And what it does is it recognizes that every person, every individual, has their own cultural perspective, which is shaped by factors such as their race, ethnicity, nationality, gender, religion, socioeconomic status, etc., etc. And what it does is it contrasts that with something called cultural competency. And some of you will probably have had cultural competency training, and the cultural competency training model is a model where essentially you learn about a specific cultural belief system, and there's almost a sense of having a fixed endpoint. Now you know about what X population group believes. Done. Cultural humility really moves away from that. It encourages people to think that culture is changing and is dynamic, and adopt a mindset of continuous growth and humility. Essentially, it means that we have to listen better to our students, our patients, to understand what their lived experience is. I give an example here, and I give an example of my dad. So I'm a Scottish mongrel. That's my identity. My parents are largely Indian. I was born in Ireland and I moved here when I was little. But my dad is quite a strict Hindu, but his favourite meal, as you probably would expect, is beef steak. Now that doesn't fit with the cultural competency model, because Hindus, according to that model, don't eat beef, but it might fit with the cultural humility model. I'm sorry, Dad. The workshop has a series of learning outcomes, and essentially expands on some of the concepts and ideas within this talk by focusing on two scenarios. And I'm going to come to the scenarios in a second, but firstly, I thought I'd just kind of run through what the concepts are. I'm not going to discuss these. I'll discuss these with reference to this cases. I think these are the kind of concepts where if you discuss them without having a kind of case, it can become awfully dry. But that's what we cover. The two scenarios are, firstly, a scenario in which a patient discriminates against a student and intends to reflect a real scenario, or a more realistic scenario in which we may well sympathise with both the student and the patient. And we have to balance both our need for patient safety with our need to support the student. It asks us to think about when and how we might intervene, if we do at all, and what we need to consider before doing so. And the second scenario uses guidelines that many of us will be familiar with, which are the NICE hypertension guidelines, and asks us if the medical guidelines themselves are racist. More broadly, asks us and makes us think a little bit about what we do when the evidence might not be perfect. Increasingly, medicine is evidence-based, but when we start critiquing that evidence base, how do we then act as doctors, and how do we then teach medicine? And there's greater knowledge now that the clinical signs that we recognise in the evidence base might not reflect all the populations we serve. Ultimately, equality, diversity, and inclusivity is here to stay as a part of our medical curricula, and it's right that it does so. It can also be a lens to think about broader issues within medicine. It can help us think a little bit about the culture of medicine, how we teach it, how we act, and how we ensure we support each other at times of unprecedented stress and crisis. And I think that's probably never been more apparent in the wake of COVID and with the stress the health system is under currently. It also, I think, helps highlight the need to stay critical whilst practicing evidence-based medicine, so that we can provide the best kind of medicine, be the best kind of doctors we can be. That's the end of my show. There should be a slide. Let's just come up. There it is. Yeah, I'll be running a few workshops in the next couple of weeks. There's, for anyone attending the MBCHB Teaching Away Day, which I think is on the 7th of June in the morning, I'll be running a couple of workshops then. And I've also provisionally booked Wednesday the 14th morning with the times to be announced. But if you're interested in attending any of those, just email me. My email's up there on the screen, and I will give you more information and details. I'm going to stop sharing my screen so I can see people.
That's great, Sarah. Thank you so much. I'm sorry for the interruption in the middle of it.
No, it's fine. I'm sorry about my.
I think sometimes we're never quite sure if we're seeing what everybody else in the room is seeing and what you're seeing. So I'm sorry for interrupting, but I think certainly on my screen things started happening, so we're all good, and there's nothing in the chat. So this is obviously a very important topic, and we have dedicated previous grand rounds to this sorts of topic, and I think it's just really fantastic to know that this kind of work is being organised and being taken very seriously within the medical school, whether it's here in Dundee or in our sister site in ScotGem, and you're clearly, taking this forward. Any questions from the audience, please? I presume that's Phil LeCoux, but I'm not entirely certain. Thank you. What does your term cultural violence mean?
So structural violence, sorry, is a term that's used to describe how the political, economics, and social systems. So that's the things that people can't control, and the things that are outside of individuals' ability to control, create sort of a sense of disadvantage. By, for example, putting certain population groups in certain areas, by the taxation system we use, anything that's really kind of governs how we work in a society. It's a sociological term.
Thanks so much. Does anybody else have any questions? Anyone is only? I'll try and search for hands up or put questions into the chat box. In the postgraduate education world, with NES, we spend a lot of time talking about differential attainment, about the very clear evidence that white UK graduates who were born here, graduate here, do better. And I think we have been guilty over the last probably 5 years or so, and I appreciate COVID got in the way, but of looking at that and saying, is this real? Are there confounding things? Is it more about where you live and the opportunities that you have, rather than just saying, well, what do we do about this? And I think we've perhaps reached a bit of a tipping point now where we're stopping just looking at all this data and saying, isn't that interesting? And is it right to trying to actually find some solutions to differential attainment? And I don't pretend to have those solutions, but I am encouraged that there is work going on to try to find them. And I think the lived experience is something we talk about a lot in clinical medicine, but I think this is really important for people from that backgrounds who are not white, educated here, or of, you just describe yourself as a Mongol. I think that's probably being harsh on yourself, but people who have mixed backgrounds, and to say what was it actually like, and what would have made a difference. I've filled enough time that someone's put their hand up, and it's Dr. Rebecca Andel. Hello.
Oh, hello, and thank you for having this talk today. I am someone, I consider myself a GPSC 50 now at Scotland, both an international medical graduate and recently diagnosed dyslexic, trying to sit my third attempt at my AKT exam, and wondering what your thoughts are on supporting us, other GPSD3s in my position, who's perhaps completed all of the rest of our requirements, and this last hurdle seems to be a hoop that we have to jump higher through.
So I'm not going to put anyone on the spot, but I would turn that round, and I think the approach I would take is to ask, it would be to try and understand and evaluate what's been difficult, what's been less than straightforward, and how we can try and mitigate and support that, as opposed to try and suggest that there's a one kind of answer fits all solution. And I think that kind of fits with the model. I think we need to better understand the challenges facing students from non-traditional kind of backgrounds, or with or from underrepresented groups, and how we can support them along the way. And at an undergraduate level, it starts at the very beginning, doesn't it? It starts with widening access programs and how we enter people into medicine. And we're not talking about any program, I'm talking across the UK. And in fact, across the world. Before here, I worked in Australia in a similar kind of role. And just admitting people into a program isn't enough. We need to ensure that any program that does so provides support along the way, and at regular intervals across the way. I think that's the gold standard, because there's a danger. And again, I'm talking broadly. When we look at people from non-traditional backgrounds, that they might be more likely not to succeed initially. So without that support, they're less likely to succeed. And then there's a danger that becomes a bit of a self-fulfilling prophecy. It becomes harder to then succeed, having not succeeded once, because of all the things that affect any of us. There's increased anxiety, increased nervousness entering those exams. We question ourselves more deeply than we had previously. So the real solution is to try and mitigate that before it becomes a problem, by providing the right support. For those like yourselves who've kind of struggled and are there now, I think the thing I've learned is to say it's often not about yourself. So it's worth pulling back from self-critique and the kind of negative thoughts about yourself, but thinking a little bit about, when I look at the big picture, what can I do? What can there be? What else is surrounding me? Because what I see, in particularly students as opposed to postgraduates, is that those who lack confidence and are struggling will put so much pressure on themselves that they think the only way to do better is to run on that treadmill faster and faster, even if it's putting in slightly the wrong direction. And actually just taking a little bit of a step back and trying to reevaluate where you're at, and trying to spend that time to steer yourself in the right direction, and then then restart and get momentum is often a better way. I'm not sure if I addressed your question there, Rebecca, at all. I'm sorry.
No, yes, no, thank you. Luckily, I'm very well supported here in Scotland. So, but thank you. That was very, very good.
I think it shows, Sarah, that there's a lot to talk about here, and I did say, we need to start doing things rather than talking about it. But it's very hard, actually. It's if it was a simple solution, we'd have done it, and it's not a simple thing. It's a multi-agency thing. It's about investing early in careers, early in education, supporting throughout, and we probably won't see the wholesale changes we want to see until there's been enough time for for schools to turn into early education, into graduates, into graduate education. It's a long haul, but a really important.
It is, and I think the crucial message really is to make sure it's a safe space, because we can't enter those discussions until people feel safe entering them. And I think at times it doesn't feel like it. And I think that's changing. I think that's changing a little bit now. And there's definitely a more positive kind of movement and less defensiveness than there maybe was 3 or 4 years ago. But I think it's really important that we have that safe space to have those discussions and ask those naive questions. And looking at the comment you made regarding differential attainment and postgraduate, that conversation for a long time, I think, was, constrained by people being wary of what they could say in the space not feeling safe. And actually, that's what's,
I think that's a
really step at times.
I think that's a really interesting comment. I think it's very, very true that what can we say, what can we not say, what is appropriate, what is not appropriate. And finding that safe space, I agree. I think is challenging, but really, really important. And and I say that as the prototypical middle-aged white grey-haired man in a senior position, and so I know from my own family who are they are from my stock but don't necessarily look the same, and they're certainly not typical, you might say. They say to me that it's important for them to see people that look like them or are like them or have the same attitudes as them, the same sexual preferences as them, the same, all those things that we're talking about. So to see a mixed faculty, for want of a better word, to pick out they look like me, I think is really important. Catherine, you have your hand up.
Yes, hi, good afternoon. It's just to check, what workshop is already in place to train, educate, tips, like real life tips of how to handle discrimination, harassment and all that, situation that isn't already in place in the university?
Yeah, so that the staff workshop I signposted at the end is what I would say is the next probably port of call. So I think the university has a number of resources on which are often kind of modules on EDI issues like bystander training, active bystander training. The workshop that I've created looks at discrimination, and it looks at, as I said, how we kind of think about racism within medical evidence and within guidelines. And so it's 2 kind of interactive scenarios looking at that. That's probably the next port of call. So there are a few dates lined up. There'll be more dates lined up. We're probably looking at running this 30 times or so throughout the rest of the year.
So is that part of the OPD? Is that in the OPD or is that a separate workshop?
It's separate. It's going to be released through probably, I think we're going to release it through Jordan Napier's work.
Okay.
Okay. So there'll be links up through that coming, and they'll be imminent.
Yeah, no, that's interesting because it's something that the NHS BAME network is kind of like looking into, hoping to put something in place too for the NHS staff and students and, guests and public, visitors. But yeah, it's just really, it's, what I'm thinking is like, instead of like duplication and doing more work, I wonder if, if there's going to be a cross collaboration between the university and yourself and the NHS.
Absolutely, mate. It's for, yeah, absolutely. I wonder, Catherine, do you want to, can you send me a message offline and we can pick this up and
Yes,
make
that
it
would
happen?
be great. That will be great. Thank you.
Great.
Does anybody else have any questions or comments? Nothing in the chat apart from people thanking you for the talk, which I think I will echo. So I'll draw things to a conclusion then. Thanks very much for coming along, Sarah. Thanks to the audience for joining today. Really important topic, and I'm really pleased that you're able to come and share the work that you've been doing and your expertise in this area. And thank you to those who had some questions and insights. Like I said, there's no, I don't have a talk scheduled for next week. And I would step in and do something myself, but I'm afraid I'm on call next week. I'm pretty busy, so I can't guarantee I would even make it. But if you have a talk, if you would like to present something next week, then please do get in touch and we'll try and facilitate that. Then we have a couple of weeks early June where we do have some talks, and then we might draw things to a conclusion. But if you have a talk and you'd like to present, please get in touch. If you have missed some Grand Rounds and you'd like to catch up, then you can go onto our YouTube channel. Just go onto YouTube and search for Dundee Grand Rounds and it comes up. It's the very first thing that you see. So that's you. And you can catch up with Grand Rounds going all the way back to 2015. So you can watch and marvel that I'm wearing the same shirt that I did 7 years ago. All that's changed is my hair is a bit grayer. Now, the last thing to do is to just share my screen very briefly so you can see the QR code. Here we go. He says, so if you'd like to get a certificate to say that you've been to Grand Rounds today, then you can just scan this QR code with your phone. It will take you straight to the sign-up sheet. Then you can stick in the title of today's Grand Round, the date, and it will it'll record for us that you've been here, so we know that you're here, and that helps us in terms of what we're doing. But it also gives you a certificate that you can put into your CPD diary or equivalent for your appraisal or equivalent. You can use this same QR code to retrospectively register for Grand Rounds you went to before, or for the Grand Rounds that you watch on YouTube, including this one once I've uploaded it. Thanks very much again. I hope you all have a good weekend and the sun stays out, and I won't see you next week because it's a week off, but then we're back again in a fortnight. Thanks very much, everyone, and take care.